Happy morning, dear students. Today we are going to discuss about nursing management of common neonatal disorders. Introduction. Neonatal disorders mean disturbance of normal state of body, organs and abnormal functions of newborn. Obstetricians plays a major role to minimize the number of neonatal disorders. Prematurity, respiratory dysfunctions, birth trauma, congenital malformations, neonatal infections, and hematological disorders of the newborn are some examples of neonatal disorders commonly encountered. Preventive obstetrics is most important in reducing these disorders. Regular antenatal checkup, balanced diet, iron and folic acid tablets, avoiding repeated pregnancies are some measures which can prevent the prematurity. Okay, this is about the introduction of common neonatal disorders. Any factor with the cause maternal hypoxia during pregnancy or responsible for fetal hypoxia. Proper antenatal care and avoidance of narcotic drugs in pregnancy are the pillars to combat respiratory dysfunction. Obstetricians play an important part to minimize the birth trauma, which is single-handedly an important example of neonatal disorders. Proper antenatal care to detect any obstetrical anomaly, reducing birth trauma to a large scale. Okay, this is about common neonatal disorders. Introduction. And coming to the classification of neonatal disorders. Here given for classifications. First one is disorders of birth injuries. Here because of during birth injuries, during delivery some birth injuries is affected to that baby, so that also one of the common neonatal disorder. And second common neonatal disorder is it is related to physiological factors. Mostly physiological factors are associated with the jaundice or hemolytic disorders, that is Rh negative mothers. Those are comes under the physiological factors. And third one is disorders related to the infectious process. Here the disorders are associated with the infectious process, which is means here the sepsis, neonatal sepsis and some related problems is associated. And fourth one is disorders related to the maternal conditions, mostly diabetic mother, that also is one of the causes disorders related with the maternal conditions. These are the four classifications of neonatal disorders commonly affect the newborn babies. Okay, what are the four classification? Disorders, birth injuries, disorders related to the physiological classification, disorders related to the infectious process, disorders related to maternal conditions. Okay, these are the four classifications. We will discuss one by one. Classification of common neonatal disorders. About birth injuries, the first classification, that is what are the conditions is comes under the birth injuries, means because of improper handling of the baby during the labor, during the delivery, that time some birth injuries may be affected because of short decisions, delayed decisions, that also may cause the baby suffering with some birth injuries. What are the birth injuries is most common in neonates, means first one is CAPUT succedanum, second one is cephalohematoma, third one is fractures, fourth one is facial paralysis, fifth one is EPS or brachial palsy. These are the five causes, five conditions mostly we have seen under the birth injuries. Commonly it may be effective in the newborns. Okay, we will discuss one by one. Okay, after that, this is the first classification conditions, and second classification conditions are here the disorders are related to the physiological factors. The first one is hyperbilirubinemia and hemolytic disorders like Rh negative mother. Okay, those two conditions are comes under the physiological factors. Okay, and next one is third disorders related to the infectious process, that is sepsis, necrotizing enterocolitis. Here the necrotizing, here the necrosis of the intestines may be present in the newborns, that also one of the infectious cause. And next one is respiratory distress syndrome. These three conditions are comes under the infectious process. Okay, disorders related with the infectious process. And fourth one is disorders related to maternal conditions, that is infant of diabetic mother. Okay, baby is suffering with the diabetic mellitus. Okay, these four conditions are mostly more commonly we have identified in children, newborns. Okay, we will discuss those conditions one by one. In first one is birth injuries, no, under that head injuries. Head injuries are what are those means? Caput succedaneum, cephalohematoma, injuries to the head while the birth. While we are observing whether any head injuries is there or not, means you should follow this scalp formula. Here the S for skin, you should assess the skin carefully because full of hair is there, no, whether any incision or some abrasions, some it is there, means we can't recognize because full of hair is there over the baby scalp, but you should check about the skin. And then next one is C. C for close connective tissue and cutaneous vessels and nerves should be assessed. Okay, next one is A. Here you should assess the apteneurosis, means here the epicranial apteneurosis. Here you have to check about epicranial apteneurosis condition, what it is there. Okay, above the cranium. Okay, how it may be, the skin it should be, everything you should assess. And next one is L. Loose connective tissues, how far, because of scalping of the layers, whether it is there or not, everything you have to check. Next one is periosteum of the skull bones. These you should assess while you are checking about head injuries, that is caput succedaneum and cephalohematoma. Okay, that is about scalp, SCALP. And first we will discuss about the caput succedaneum. What is caput succedaneum? Means the edema of caput succedaneum crosses the suture lines. Already this class is over. Okay, here the edema is forming over the parietal bones. But here the edema is crosses the suture lines. It often appears over the vertex of the newborn's head and results of pressure against the mother's cervix during the labor. So because of some pressure is there during second stage of labor when the head is passing, because that time during that time some delayed process is there, that time the fetal head may accumulate the edema. So it is called as caput succedaneum. A caput succedaneum is an edema of the scalp at the neonates presenting part of the head. Okay, this is about the caput succedaneum. Next, coming to the causes of caput succedaneum, that is prolonged or delayed delivery, vacuum extraction. Nowadays it is not done, but because of vacuum extraction, that time also baby is suffering with the caput succedaneum. And next one is a mechanical trauma of the initial portion of the scalp pushing through the narrowed cervix. So for example, if the cervix is narrowed or some narrowed pelvis, that time also the head is unable to deliver. That time also because of some delayed second stage of labor, it may happening. That is caput succedaneum, injury to the head. Okay, these are the causes. And next one is cephalohematoma. Okay, cephalohematoma. What is cephalohematoma? It is a collection of blood between the periosteum of the skull bones and the bone itself. It occur in one or both sides of the head. Look at that picture. Here the both sides it is there. What is the main clinical feature of this cephalohematoma? Means it won't cross the suture lines, but caput succedanum it may cross the suture lines. Okay, so look at that picture. In between the sagittal sutures is there, no? Here it won't cross the suture lines, that hematoma. Okay, the swelling with the cephalohematoma is not present at birth. Rather, it develops within the first 24 to 48 hours after birth. Has clear edges and at the suture lines. Here we will clearly we will identify. The swelling with the cephalohematoma is not present at the birth. Rather, it develops within first 24 to 48 hours after the birth. Okay, this is about the cephalohematoma. It is the blood is collected in between the periosteum, but it won't cross the suture lines. Okay, causes. Here the causes means instrumental delivery, rupture of the periosteum capillary due to the pressure or of birth. These are the causes of cephalohematoma. Next one is nursing care about injuries to the head. Here it is directed towards the assessment and observation of the common scalp injuries and vigilance in observing of possible associated complications such as infection or acute blood loss and hypovolemia. And next nursing management is because of visible injuries resolved spontaneously. Parents need a reassurance of their usual begins the nature. Okay, this is about the nursing management of head injuries. Okay, next one is fractures. Here the fractured clavicle. Okay, here the what is fractured clavicle in the newborns means bone may be bone most frequently fractured during the delivery. This clavicle bone most frequently fractured during the delivery associated with the CPD signs. CPD signs means cephalopelvic disproportion because of head the fetus cephalus it is not proportionate to the mother's pelvis. The reason disproportion is there. That time the narrowed pelvis the fetal head is big, that time it won't pass, that sometimes some obstruction will be there. So those conditions only this fractured clavicle may be occur. And how that baby when the fracture clavicle is there, that time absence of moro reflex on affected side is there, cries of pain when arm is moved. And cryptus, here the cryptus means some cracked sounds, some sounds may be produced because of that fracture. And child is limited the ROM range of motion it may be there. And any newborn that weighs more than 3.8 kgs and is delivered vaginally should be evaluated for the fractured clavicle. If it is child is having more than 3.8 kgs, that time you should suspect that some any fracture is there for clavicle, anything you have to suspect for that. And heals quickly, handle gently, immobilized arm, eliciting scarf sign is not contraindicated. Here the whenever you are assessing gestational age assessment, that time we are using scarf sign. Okay, that time whenever the child is suffering with the clavicle fracture, you won't do for that clavicle scarf sign. Okay, this is about the fractured clavicle. And what is the management for the fractured clavicle? The parent should be involved in the care supporting the baby for upper and lower back other than from under the arm should be practices here. And then often no interventions is needed other than maintaining proper alignment, careful dressing and undressing of the infant. This is very important for that baby, fractured clavicle baby. Okay, and next one is facial paralysis. What is facial paralysis? From pressure on the facial nerve during the delivery, affected side unresponsive when the cry resolves in the hours or by the days. Here, because of some facial nerve pressure, that the facial paralysis may be occur. Okay, it may reverse within hours or days. Okay, this is about the facial paralysis. What is the nursing management? Here the management is divided. The feeding may be given by gavage in order to prevent the aspiration, because baby is unable to close the mouth properly, baby is unable to swallow, unable to suck, everything is there. So whenever you are giving a feeding, that time aspiration may be occur. You should be careful to prevent of aspiration. Okay, so gavage feeding is very very important. And since the eye on the affected side cannot be closed completely, it is covered with eye shield to prevent the drying of the eye and then conjunctivitis of the cornea. Okay, so we have to protect the eye because the baby is unable to close that affected side, close the eyes for that affected side. So you have to provide the eye shield to prevent the dryness of the eye and then conjunctivitis of the conjunctiva of the cornea. Okay, this is about the management of facial paralysis. And next one is Ebb's palsy or Ebb's Dowshney paralysis. What is the Ebb's palsy? Means associated with the stretching or pulling head away from the shoulders during whenever we are checking. Here the arm also may be extended. Okay, this is about the Ebb's palsy, here associated with the stretching or pulling of the head away from the shoulder during the during that time it may be occur. And next one is what are the clinical features, the signs? It is a flaccid arm is there. Here the arm is unable to move, elbow is extended. Look at that picture how the elbow is extended. Hand rotation inwards, here the hand is rotated inwards to the towards the abdomen, and hand rotated inwards, and moro clasp reflex is absent on affected side. Here the moro reflex and then grasping reflex is affected for that side. Required immobilization and repositioning within every 2 to 3 hours. Okay, this is about the clinical features of Ebb's palsy. And nursing management of Ebb's palsy. The goal is to prevent the contractures in paralyzed muscles. The arm should be particularly mobilized in the portion of maximum relaxation so that the non-paralyzed muscles cannot expert pull on the affected muscles. By using of splints or brass when the upper arm is paralyzed and arm is abducted 90 degrees and rotated externally at the shoulder with the elbow flexed so that the palm of the hand is turned towards the head. Okay, this is about nursing management. When any form of immobilization is used, the fingers and hand should be observed for coldness. If any, because of for that splint, sometimes because of immobilization, because of that using of brass or because of using of splints, what happen means extremities should be cold and clammy, some necrotization may be happening, and discoloration may be there. That time you should follow about what are the clinical features of signs are there for the skin. Okay, everything, any irritation or any skin problems or discoloration, everything you have to check. This is about the nursing management. Next condition, this is the disorders of the physiological disorders. In second condition, under that hemolytic disease of the newborn. What is hemolytic diseases of the newborn? Means here Rh positive, here the Rh negative mother, but here the Rh positive is D antigen is present, Rh negative mother is having lack of D antigen. Look at this picture. Here the Rh negative mother is not having D antigen. Rh positive, it is having the D antigen. So we will discuss here. When Rh negative, Rh positive blood is infused into the Rh negative woman, What happen? Through the error, or when the small quantity, usually more than 1 ml of Rh negative fetal blood containing D antigen inherited from an Rh positive father. So here what happen, enter the maternal circulation during the pregnancy with the spontaneous or induced abortion. Sometimes spontaneous or induced abortions may be occur, or at delivery antibody fermentation against the D antigens is there. So what happen means in this hemolytic disorders means when mother is Rh negative means she is having negative blood group, means father is having positive blood group. What happen, because of that baby also is having positive blood group, it whenever any injury or some any maternal it may enter into the maternal circulation. What happen means automatically abortions or spontaneous abortions or induced abortions may be happening. But how we have to prevent this means here we will give I will ask one question: why the fetus is affected in the first fetus is not affected and second baby is affected, means look at this, why the fetus is affected in the second delivery and not in the first delivery, means first first baby is not affected, second baby is affected. Why? What is the reason? At the maximum of blood usually occurs at the time of delivery, so by the time antibodies are formed the baby is already is delivered. So but when if the mixing of blood occur before the delivery, let's say during some procedure like amniocentesis or chorionic villus sampling, now will the fetus be at the risk. Whenever you are not doing any some amniocentesis or chorionic villus sampling, that time it won't be affect the first child. Okay, but why the fetus is not at risk during the first pregnancy even if the blood is mixed before the delivery, means here why the first baby is not affected than the second baby, means the answer is because of the type of antibodies formed during the first and second delivery. Okay, this is about and prevention of hemolytic diseases. How we have to prevent this hemolytic diseases means Rh negative, Rh positive. Okay, here the prevention, Rigum. Here the anti-D in unsensitized mothers we have to administer. The treatment of mother with RHD antibodies prior to and immediately after trauma and delivery destroys the Rh antigen in the mother's system of the fetus from the fetus. The treatment is IVIG immunoglobulins is given in infants and exchange transfusion and phototherapy is needed. Here the anti-D immunoglobulins is given to the mother, not the baby. But the immunoglobulins are given to the baby and then exchange transfusion and then phototherapy is needed for the baby. Okay, this is for the baby treatment. Okay, and next one is next condition. These are also physiological conditions. What are those means neonatal jaundice. First we discuss hemolytic disorder and next is neonatal jaundice. It is a yellowish discoloration of the white part of the eyes and then skin in a newborn baby due to high bilirubin levels. The symptoms, the other symptoms may include excessive sleepiness or poor feeding, and complications may be include seizures and cerebral palsy may there for the for that babies. Okay, this is about neonatal jaundice. How you have to decide that that baby is suffering with the neonatal jaundice means if adult scare is when you will decide that child is they are suffering with the jaundice means if they are having bilirubin levels more than 2 milligrams per dl, that time you have to decide. Okay, if it is decide in adult is having jaundice, in newborn skin is more than 5 milligrams of bilirubin levels, that time we will decide that neonatal jaundice is there. Nursing management of this hemolytic disorders. Here the hemolytic disorders, how we will manage means early recognition of jaundice. If exchange transfusion is required, Then the nurse prepares the infant and family assist the physicians. The nurse the nurse documents the blood volume exchanges and everything she has to document. Signs of blood transfusion reactions are needed to be monitored. And next one, throughout the procedure, infant thermoregulation needed to be monitored. And after the procedure, the nurse monitor the umbilical cord for any kind of bleeding. This is about the nursing management of hemolytic disorders. What are the two conditions we discussed in hemolytic disorders? Means that is jaundice and then Rh negative. These two are comes under the disorders of physical common neonatal disorders physiologically. And next one is neonate respiratory distress syndrome or hyaline membrane disease. Here the what is hyaline membrane disease or respiratory distress syndrome means it occurs primarily in the premature infants. Incidence is inversely related to gestational age and birth weight. It occurs 60 to 80% in infants less than 28 weeks of gestational age. Okay, if child is having preterm means less than 28 weeks of gestational age, this RDS may occur 60 to 80%. If child is having 32 to 36 weeks, the percentage affected percentage is 15 to 30% is there. Okay, if a child is having beyond the 37 weeks, rarely at the term, the RDS is affected 5% only. Okay, when who are the affected persons means preterm infants are most commonly affected. Means 60 to 80% who is having means less than 28 weeks of gestational age, preterm babies. Okay, this is about the respiratory distress syndrome. And the condition occurs due to lack of pulmonary surfactant because of immature of the lung. The surfactant help in reducing the surface tension of the alveoli. When the surfactant active maternal material is deficient in the alveoli, there is a alveolar collapse during the expirations. Here, because collapse of the surface tension alveoli when it is may occur means whenever baby is taking aspiration, it may be present. The pulmonary immaturity of the fetal lungs can assess by the determination of lectin and sphygmomyelin ratio in the amniotic fluid. Okay, whenever we are assessing the amniotic fluid, that time it may how much the lung is maturity we have to determine of lecithin and spinogomyelin. Here the ratio we have to assess whenever you are checking the amniotic fluid. Okay, and next, what are the clinical features of respiratory distress syndrome or hyaline membrane disease? This is characterized by triad of trachypnea, expiratory grunts, inspiratory retractions in the preterm. Here the grunting sounds, trachypnea, retractions, everything is there in the preterm. And neonate respiratory distress syndrome also may be present. These symptoms may being at the birth within the 6 hours of the birth. And there is a gradual worsening of the retractions, grunting and cyanosis may be present. Okay, and management of the respiratory distress syndrome. The premature labor should be arrested by the appropriate trochollytic therapy to gain pulmonary maturity. The induction of labor should be delayed as far as the lung maturity is confirmed by ratio. Here it is how much the lung maturity is there, everything you have to check for their symptoms and their ratio. When the premature labor below 34 weeks of gestational age is unavoidable, the mother should be given beta-methogen 12 milligrams IM every 12 hours for 2 days, or dexamethasone 6 mg IM 4 doses at an intervals of 12 hours. Mostly you have to delay the labor only, okay, or before induction you have to assess the lung maturity. If the lung maturity is not there in the baby, how what they are doing means they has to assess how many weeks is there. If it is below 34 weeks is there, means how much the injection dose beta methadone is given, means 12 milligrams is given within every 24 hours for 2 days. If dexamethasone you are using 6 milligrams IM, means you should give 4 intervals, okay, every 12 hours you should be given, okay. The infant should be nursed in a thermoneutral environment and administer the oxygen through the head box or a hood, oxygen hood. You should measure the SpO2, should be monitored. Okay, here you should monitor everything. Okay, before that, whenever any induction of labor, any delivery process is there, first you have to check about the lung maturity, how many weeks is there for that baby, and then assess. After that, you should administer the dexamethasone according to the doses wise. And that is about the nursing medical management. Coming to the nursing management of RDS, means effective ventilation and oxygen therapy should be provided, and equipment should be ready and in working condition. Oxygen must be warm and humidified should be the air, and the conditions of the infant can change in a fraction of a second. So it is vital for the nurse to monitor the neonate color, level of activity, and to not and to note blood gas measurements. And when oxygen is given, tracheal and nasopharyngeal suction and chest physically therapy is needed. Okay, required. It is required. This is very important. Nursing management is very important for the respiratory distress syndrome babies. First, you should monitor the child condition. After that, you should administrate oxygen, because the child condition is worse. Whenever easily the condition may be changed within seconds, so the vital signs you should be monitored carefully. And next one is optimal environmental temperature. The nurse has to has a important role in improving in providing regulation of surrounding temperature. Here she has to maintain warmth for that baby, and maintain the thermoregulation to that babies, okay. And next one is adequate nutrition. Proper gavage feeding at the proper intervals is necessary. Nursing actions should be taken. And minimal handling of critically ill infants. Use of aseptic technique. Infant should be positioned with head elevated to decrease the pressure on the diaphragm. So because of elevation, automatically some respiratory distress may be decreased. That is about the management of respiratory distress syndrome. Okay, first you have to maintain ventilation and oxygen therapy, and optimal environmental temperature should be maintained. Adequate nutrition and minimal handling is very important for respiratory distress syndrome baby. And next one is necrotizing enterocolitis. Okay, here the necrotizing enterocolitis. This condition is characterized by necrosis of the intestinal wall. Is a serious life-threatening condition that is being diagnosed with the increased frequency of premature infants. Increasing the frequency in premature infants. Here most commonly we are seen in the premature babies only. What it is, necrotizing enterocolitis means mostly here the because of necrosis of the intestinal wall, this distension of the abdomen will be there, and then some it is life threatening condition. Okay, what are the factors that place the infant at risk of this disease, including first one is sepsis, IRDS respiratory distress syndrome, and low Apgar score, and perinatal asphyxia, and some babies are needed for the exchange transfusion, no, if it is severe jaundice, that time they are using, and use of umbilical catheters, relative ischemia of the intestinal tract, that is due to hypotensions, and congenital cardiac diseases, eternal feeding. These are the common factors that plays an important risk factors of this uh, necrotizing enterocolitis. Okay, and necrotizing enterocolitis clinical features or manifestations, means abdominal distension. I said no, it is an necrotizing of the intestines. No, first automatically abdominal distension is there, and decreased bowel sounds and poor feeding. A baby is unable to take proper feeding, and increased gastric residuals, and blood streak, bile vomiting, it should be there. Whenever baby is vomiting, it may contain blood streaks, bile also is there. And next one is bloody or mucoid stools. Here child may passing the bloody or mucoid stools. Okay, and what is the nursing management of this enterocolitis? Means here, as soon as the diagnosis of NEC, necrotic necrotized enterocolitis is made, the oral feedings are discontinued, and peripheral IV fluids are given to the baby or infant. The main nursing role is whenever you are suspected that child is suffering with the necrotic enterocolitis, that time immediately you have to stop the oral fluids or discontinue the oral fluids. Peripheral IV fluids is starting for that baby. And palpations of abdominal girth are checked daily. You should check about the abdominal girth, how much the distension will be there, everything. Okay, and then bowel sound should be monitored frequently. Total parental nutrition is to be started. Okay, here first you stop no oral feeding, so you have to total parental, you have to start the total parental nutrition. IV antibiotics are started to against gram-negative and enteric organisms. Here IV antibiotics you should be started, and rectal temperature is not and taken so as to prevent the rectal perforation. Sometimes because this infection is there in the intestines, no, okay, so rectal temperature taking should not be recommended. And affected infants are to be placed in isolation, because necrosis and enterocolitis inflammation, no, it is a severe infection, so you have to isolate that baby. And fecal material can be drained into urine collection is devices. Okay, here the fecal material and everything you should be drained, and you should collect the urine also. Okay, and psychological support should be given to the parents. This is very very important. Okay, this is about the condition of necrotizing enterocolitis. Next one is neonatal sepsis. And this is also one of the common neonatal disorders, that is neonatal sepsis. It is a systemic bacterial infection of the newborn. Infants are termed as a neonatal sepsis. They are the most common cause of neonatal deaths in India, natal sepsis. Okay, this is a generic term which incorporate neonatal septicemia, pneumonia, meningitis, and urinary tract infections. When our child is suffering with this neonatal septicemia, pneumonia, meningitis, the urinary tract infections, that time you should treat as a neonatal sepsis. Neonatal sepsis can be divided into two types. First one is early onset, second one is late onset. Here how we are deciding that this is neonatal sepsis means whenever that baby is suffering with any conditions, like here within 72 hours of the life, the mainly due to the organisms present in genital tract or in the labor room or in the maternity operations. Here the through the mother is suffering with some STDs or torch infections. That time also it may transmit within 72 hours. That is called as early onset, and it may transmit in the labor room or maternity operation room. Okay, this is about the early onset, and next one is late onset. This is caused by the organisms thriving in external. Okay, the infection is often transmitted by the caregivers. By external environment, by the caregivers, they are suffering with some infections. They may carry these infections to that babies. So that is late infections. Okay, this is about two types of neonatal sepsis: early and then late. Early means within 72 hours child may suffering with sepsis. Clinical features of the neonatal sepsis: active baby suddenly becoming lethargic, any altered in the feeding pattern is there, and episodes of apneic spells with cyanosis may also be one of the sign, and hyperthermia in preterm and fever in the term babies, especially in associated with the gram positive infections and the meningitis. And next, diarrhea, vomiting, and abdominal distension, jaundice, and hepatosplenomegaly may be present. And these are the clinical features. And next one is neonatal sepsis management. What is the management of this neonatal sepsis? Is the infant should be managed in the thermo neutral environment, and started on the intravenous antibiotics. You should start the antibiotics for the prevention of the sepsis. Next, nursing management of neonatal sepsis: hand washing and uh, thorough scrubbing with the soap and water up to elbow for at least 2 minutes. Okay, 2 months you should be follow for that. Wearing of gowning and changing of shoes are mandatory. Okay, next one is rings, bracelets, wrist watches should be removed whenever you are handling that baby. And next one is strictly hand washing for 20 seconds and use of antiseptic solutions in between the handling of the baby. You should follow for that. Babies should be feed early and exclusively on the breast milk. Careful attention should be paid to hygiene, to the cutlery and then spoon feeding. Whenever you are giving the artificial feeding, that is cutlery or spoon feeding, that time should paid proper hygiene is maintained or not. The umbilical stump should be left open. Okay, so whether it is dry, it is there drying or dry, it should be dry is there, and local application of spirit reduce the colonization. Okay, and next one is all procedures should be done wearing of mask. So you have to prevent the septicemia for that baby. Unnecessary needle pricking should be avoided. Strict housekeeping routine for washing, disinfection, cleaning of the cots, incubator should be ensured. This is about the management of the neonatal nursing management of neonatal sepsis. And next one is infant of next condition, that is infant of the diabetic mother. Okay, this is also one of the common neonatal disorder. Okay, what is infant of diabetic mother? Means a fetus of or baby mother with diabetic may be exposed to high blood sugar or glucose levels and high level of the other nutrients through the pregnancy. Okay, this is about the infant of diabetic mother. Means here the mother is suffering with the diabetes. So that baby is got the high blood sugar levels, at the same time high levels of other nutrients also is enter into that baby. What are the causes of this infant of diabetic mother? Here means the first cause is gestational diabetes. Gestational diabetes means high blood sugar, that is starts here the diabetes that starts or the first detected during the pregnancy, that is called a gestational diabetes. whenever mother is suffering this diabetes during the pregnancy, that is called as gestational diabetes. Second one is pre-existing or pre-gestational diabetes, means already having the diabetes before becoming the pregnant. These are the causes. First one is gestational diabetes causes pre-existing or pre-gestational diabetic. These are the two causes for that infant of diabetic baby, diabetic mother. What are the clinical features of this infant of diabetic mother? Means the baby should look like, whenever you are observing large for the gestational age, baby become more than 4 kgs, and then weight is there, and then very plump and full faced is there. Here look at that picture, how the baby is look like, very pulp and full face is there, and abundant vernix caseosa is there. Here the child is having more vernix caseosa, um, pleothera also is there, and baby is restlessness and then lethargic. Baby is not having proper reflexes also, and then babies lethargic look like lethargic and inactive, and a large placenta and umbilical cord is there whenever baby is delivered. The placenta also is very large, and then umbilical cord also is very big, and possible meconium strain at the birth, because this baby is unable to pass, no, so meconium, because of some asphyxia, meconium strain also is there. And coming to the nursing management of infant of diabetic mother, that is early introduction of carbohydrate feeding as appropriate, and serum glucose monitoring should be there, because of macrosomic infant are at high risk of problems associated with the difficult delivery. They are monitored for the birth injuries, because big baby, some birth injuries may be having for that baby, so you have to monitor. And there is some evidence of IDM, infant diabetic mothers have an increased risk of acquired type 2 diabetic mellitus during the childhood or early adulthood. Therefore, a nurse should also focus on healthy lifestyle and prevention later in life with the IDM, insulin diabetes mellitus. Okay, this is about the nursing management of infant of diabetes mellitus. Thank you. These are the conditions of non